Have I stopped sharing? Yes.
Yes.
Yes, I have.
Good evening, everyone, and nice to see you again, theoretically. Today, I'm going to discuss ultrasound of the fetal heart, the typical views, and how to obtain them. This is not a talk on fetal echocardiography. We will be discussing some pathology. We'll not be doing a lot of Doppler and things like that because there's only so much you can do in the time. For a true fetal echo course, you would need at least 8 hours, preferably 2 full days. So this is more of the normal anatomy and how to obtain the views. Unfortunately, due to the limits of COVID, I'm not able to get into the clinical world, and I was not able to do live video, at least on my end, but you'll see how I improvised. COVID I think, is all about improvisation. So we're going to look at the normal anatomy and its appearance on ultrasound. We'll talk about normal position and situs and identify abnormalities of structure or rhythm. Some of what I have has come from the ISUA guidelines. These were from 2013. They all still apply. And in addition to that, I have information from several other sources, all referenced on my slides. And some of you may be familiar with Dennis Wood. He's a world famous fetal echocardiographer. And with permission, I have some information from him, and I have given him credit as well. So what is your target when looking at the fetal heart? It's not large, let's put it that way. This is a 20-week heart and a quarter, United States quarter. So we are looking at a fairly small structure, which is why technical settings, and Dr. Simon a few days ago talked about some technical settings, really well done. And it's all very important, using high frequency transducers when you can, linear transducers when you can, because it's amazing the detail that we can see, even at 22 weeks, 20 weeks, let alone in the first trimester. So when we look at the heart, there's a few things we can look at that are not just anatomical, but ultrasound is a dynamic study. So one of the things is looking at not only structure, we're going to look at the structure. We have 2 atria, 2 ventricles, and some great vessels that we're going to look at. But it's also important to look at the function. So when we look at the heart, we're going to look at the squeezing motion. We're going to look at the valvular motion for the 4 major valves that are in the heart. And in addition to that, we'll look at proportions and things like that. So the 4 key things are position. On what side is the heart? The size, not only what side is the heart, but in what direction is it pointing? Because not only should the heart be predominantly on the left, but it should also point towards the left, and we'll talk about that. The size of the heart, it should take up 1/3 of the chest. You should be able to put 3 hearts in a chest. The heart should squeeze, not rock. And the rhythm, it should be a regular rate and rhythm. As Dennis Wood says, you should be able to dance to it. It's important, and this was mentioned the other day as well, to label your 4-chamber heart view and your stomach views, either in subsequent images, one after the other, or better yet, on a split screen, to not only show that the 4-chamber heart and the stomach are on the same side, but that side is the left side, the fetal left. Whenever we say left, right, it's always in reference to the fetus, because of course the fetus can be in any position. I have 2 Dennis Woodisms that I'll mention, but he told these to me over 20 years ago, and I've been using them ever since. If it doesn't look right, don't make it look right. And I can't tell you how many times I've used this principle. You can't get a 4-chamber heart, and you keep scanning and you can't get a 4-chamber heart. So you take something that's sort of looks like a 4-chamber heart and you label it 4-chamber heart, and the baby is born with a cardiac defect. Now, that's never happened to me that I'm aware of. Why? Because I don't try to make it look right. If I can't get a 4-chamber heart on a fetus where I should be able to get a 4-chamber heart, I follow the next rule. When in doubt, send it out. Which means if I'm in a perinatal center, if I'm in a radiology center, I'll send it to perinatology. If I'm in a perinatology center, I'll send it to fetal echo, because I'll question it. The key thing is I'll question it. Remember, I'm a sonographer, not an obstetrician. So somebody else always has to look at my stuff. So usually it would be a perinatologist, and I would just tell them it doesn't look right. And that's all they need to hear. They're going to get a fetal echo done and try and figure out what's going on. Usually I can figure out what's going on, but still the official thing is they need a fetal echo. Key points. The aorta has cranial vessels coming out of it. So when we start looking at the aortic arch view, remember to look for those cranial vessels. The pulmonary trunk branches into left and right pulmonary artery. The pulmonary trunk is always anterior. As we'll show you in a second, the right ventricle is the most anterior chamber, which means the pulmonary vessels are anterior vessels. The vessels should cross each other and not lie parallel to each other. If you see the main pulmonary artery here and you see the aorta here, notice that they cross at their base. That's very, very important, something you should look for on every ultrasound. And another Dennis Woodism, form follows function. If the function of a part stops working properly, the shape of that part or the parts that are related to it will change. So for example, if you have a fetus with a severe aortic stenosis, that means blood can't get into the left side will shut down and you have a hypoplastic left heart. So form follows function. As long as the function works, the form will work. And the rule of 4. There are 4 chambers, 4 valves, and 4 vessels that we need to routinely look at. As far as rate and rhythm, in the second and third trimester, the typical heart rate is around 110 to 160. That the heart rate can go up, of course, with fetal activity. It should never be below 110. An arrhythmia is an irregular rhythm. They're not uncommon, but if you see them, you should document them. Bradycardia is a slow heart rate, less than 100 beats per minute. Tachycardia is a fast heart rate, greater than 160. Again, sometimes it's transient, and that's one thing, just like when you're scanning the fetal heart, especially at 20 weeks, if you're pushing, you can see the heart rate slow, just move off of it, come back. Transient is fine, persistent is not. And then the most common arrhythmia we see is the PAC, the premature atrial contraction. And I have another slide on this too, but one of the nice things is when you get your M mode cursor through, especially the right atrium and the left ventricle, you can see the ventricular contractions and compare them to atrial contractions to look for things like heart block and things like that. Fetal position and situs is one of the most difficult things for new learners of obstetric ultrasound. So this is what I use with my students. And I have a picture of a fetus. The bottom part's the cervix, the upper part's the fundus. This is a fetus lying breech face up, vertex face down, vertex face up, face down breech, and face down vertex. And what position, where is left, where is right? So where should the stomach be? Where should the apex of the heart be? In addition to that, there are hand positions you can use, and I can show more after this by unsharing my screen and using my own hand. But if you're trying to figure out what side is left, what side is right, and your fetus is face up breech, look at your hand. I have a sticker there on my colleague's finger to show that there's a smiley face on there that you can't see. This is the face, and then the back of the hand is the spine. So in a baby that is breech, because the head is up and the butt is down, the thumb always points to the left side. So if the baby were breech but face down, you turn your hand because now the spine is up, and where is the heart? It's left. And again, this corresponds, if we look at this particular fetus here, which is breech face down, notice where the heart is. It's pointing down and to the left. Notice where the thumb is, pointing down and to the left. So this is a handy trick, no pun intended, that you can use. Here you can see the smiley face. So again, similarly, and this requires a torsion of the hands. If the baby is lying vertex face up, you got to hold your hand like you're holding a box or something. You turn it around behind you, but the face is down, the butt is up, and where's the heart? Pointing this way. Notice where left side is. Here's the left side. And then again, flip your hand over, and now you have a spine up. Where's the heart pointing? The heart is pointing this way. This is fetal left. Here's fetal left. So a little trick that new learners can use. In the Abu Hamad book, which is my favorite fetal echo book, and I have, I think, 3 or 4 of them, they give you a table to talk about optimization. And optimization is so important because you could be using an older machine, but if you know how to optimize it, you're going to get great pictures and be able to make that diagnosis. Very important to know your equipment. Simply hitting the auto optimize button is not sufficient. And with ultrasound rapidly leaving, at least in the United States, leaving radiology, and everybody, literally everybody is doing ultrasound, you start wondering about how many people are just hitting the auto optimize button. Fortunately, obstetricians around the world that perform ultrasound are more familiar with these technical settings and how to optimize the images, which is good. It's especially important for fetal echo. One thing that I try to do, and this was mentioned on Wednesday or Thursday as well, is when the baby is spine down, which is the optimal position for imaging the fetal heart for most views, you can keep your transducer here, but what I try to do is shoot down the interventricular septum. I try to be parallel to the interventricular septum, and the reason is because, and here's that physics again, you want to be perpendicular to the AV valves. And the reason is because the AV valves now become specular reflectors, which makes them easier to see. So when we're trying to look at the motion of the valves and the 4 chambers as a whole for the 4-chamber view, I like to try and maneuver my transducer in order to shoot right down the interventricular septum. One thing to remember is that mom's belly is a fishbowl. We don't just have to put the probe on the top of the abdomen or pelvis and scan from that window. Especially on a patient that is of larger size or further along in pregnancy, we can come around from the side, we can come around from underneath. So unless the spine is completely up, in which case there's still some views we can get, you should be able to get most of the heart views from almost any position. Just remember that mom's belly is a fishbowl. However, for evaluation of a ventricular septal defect, when you want to look at the interventricular septum, then it's best to be perpendicular to the IVS. So I always want to get at least a couple pictures perpendicular to the interventricular septum, because in that case, now the IVS becomes the specular reflector, and I'll have a better chance, especially with color Doppler, of potentially seeing a VSD. The standard views at a minimum, even when a patient comes back for their 4th follow-up, the standard views are the 4-chamber heart, LVOT, RVOT. These additional views are all performed at the anatomy scan. So when the patient comes for their 20-week anatomy scan, according to AIUM protocol and what should be performed, we do all these views. Fetal echo would add a bunch of M-mode Doppler and measurements, of course, but that's outside the scope of an anatomy scan. Unless, of course, we suspect something, in which case we would do some Doppler as well. And many people will do color Doppler to look for a ventricular septal defect. One important reason, let me go back one important reason, by the way, that we do these 3 particular views, even when they come back at 28 weeks, 32 weeks, assuming the fetal position and size allows it, is because the heart is one of the things that can be totally normal at 20 weeks and totally abnormal at 32 weeks, 34 weeks. So these are the kidneys, the brain, the heart. There are certain structures that anytime a patient comes back for a growth scan, we should be looking at these structures because they can be normal and then not normal. The steps for sequential segmental analysis. So it's good to have a protocol. Fetuses, generally speaking, don't allow for protocols. Like, you can't always scan the spine before you scan the heart, before you scan the head. The fetus will let you get what the fetus will let you get. However, it's good to have a plan so that you don't miss anything when scanning the heart. So I always try to get the 4-chamber, then the outflows, then I'll get my sagittal views, etc. So it doesn't matter if your plan matches this one as long as you have one. So this is a pathologic specimen of the heart. And notice we have the spine, the lungs, the heart taking up about a third of the chest, and here's the anterior, the sternum. Notice that the heart lies at about a 45-degree angle off the long axis here, and notice that almost all the heart lies on the left side, and it's the apex points to the left side at a 45-degree angle. So when we superimpose an ultrasound on it, it should look the same. So again, you can see that apex of the heart in relation to the spine. In addition to that, you should always see the aorta adjacent to the left atrium, which again is what we're seeing here in ultrasound. Here's just the ultrasound image. So we have the descending aorta, the left atrium, right ventricle, and left ventricle. The left atrium is always the closest to the spine and adjacent to the aorta. The right ventricle is always the most anterior. So if you put a needle through an anterior chest, you would always hit the right ventricle in a normal heart. Then, of course, left ventricle, right atrium. The ventricles should be proportionate to each other. The atria should be proportionate to each other. Later in pregnancy, the right ventricle can be a little bit bigger than the left side. In fact, in general, right-sided heart structures can be a little bit bigger, slightly bigger than left-sided structures, but not more than slightly. Now, notice if I draw two perpendicular lines from the left side of the fetus to the right side of the fetus and from anterior to posterior, where those two lines intersect is the left atrium. And that's critical when we start talking about if the heart's lying in the correct position or if it's too big, or if it was shoved over like by a diaphragmatic hernia or something. It's very important to note where that intersection is. And you can do that visually. But if you're not sure, if I have a fetus where I'm suspicious, I'll put the two lines in on my screen. You can do it with the calipers. And I'll say, I'm not really comfortable with where that caliper is. Because remember, not only can the heart be shoved over to the right, but still be pointing in the correct direction. Or the heart can be on the left side, but maybe the apex is pointing down this way, which would be abnormal. And so there's a lot of permutations that can occur. So here's another picture showing that intersection and also the 45-degree angle. And again, these are all critical markers and things to keep in mind when you're scanning. And this is all obtained 4-chamber heart, you eyeball it, and if you do enough of these, then you can look and you'll pretty much get that buzzing in your head that tells you something isn't right. Aorta, left atrium, right ventricle. When we look at situs, and this is that side-by-side picture we were talking about, I will always document on the anatomy scan the left side of the fetus and the right side of the fetus. And again, I've been scanning for so long. Once you've been scanning for more than a year, you don't have to think about what position the fetus is in. It just is automatic. But I can just look at the fetus and know this is left and right, or know that this is a vertex baby because this is left, this is right. And again, just because of how long I've been scanning. And therefore, the stomach should be on the left and right. You come down. If you see these two pictures and you say, okay, the stomach and the heart are on the same side, perfect, this is normal, you're going to miss a situs inversus totalis. So it's very important to confirm situs. If this was a breech baby with this picture, we'd have a problem. And it does happen and it does get missed. So it's very important to actually confirm left and right by knowing what position the fetus is in and then documenting that the heart is pointing towards the left and the stomach is on the left. So let's look at the anatomy of the 4-chamber heart. There's a lot to be seen just in a 4-chamber heart. The mitral valve and the tricuspid valve, where they intersect, where they touch the interventricular septum, should not be at the same level. Notice here's the tricuspid valves, here's the mitral valve. So not only are you going to look at the motion of the valves in real time, but you need to see where they intersect. There should be a very small, just 1 or 2 millimeter distance between these two valves. If these valves are a straight line across, there may be an endocardial cushion defect. It's not a guarantee because there are normal variants based on how you angle, but you have to question an endocardial cushion defect if these valves are at the same level. The other key thing in the apex of the right ventricle is the moderator band. It just transects right across the bottom of the right ventricle. Notice the left ventricle does not have a structure like that. The moderator band is key because it's always in the morphologic right ventricle. So for example, in a corrected transposition of the great vessels, where the right and left ventricles switch places, where if you see the moderator band over here, even though that would normally be the left ventricle, because you see the moderator band, you know for a fact that that's a morphologic right ventricle. So it's very important to identify the moderator band to confirm, yes, this is the right ventricle. The atrial septum, we can look at that and we look to make sure the foramen ovale flap is in the left atrium. And of course, we check the interventricular septum to look for any obvious defects. We can miss very small VSDs even with today's equipment. Color Doppler is your friend. So here is a 4-chamber heart. And again, we're going to watch the valve motion, and very important to watch the myocardial motion in the 2 ventricles. We are able to see a foramen ovale flap intermittently here in the left atrium. We can see some pulmonary veins coming in there. But the key thing on this 4-chamber view is the squeezing of the ventricles. Again, not rocking. The heart's not rocking. The heart is squeezing. And the motion of the valves. And we can look, I have another video here from another source. And again, we're going to watch, here's the foramen ovale flap over here. In fact, I have a little laser pointer. Here's the foramen ovale flap over here. We can see the chordae tendineae and the valves moving, and that's all very important. This is a pathologic specimen in coronal plane. Again, notice the insertion of the mitral valve cusp versus the insertion of the tricuspid valve cusp. So they should always be a little offset. And here again showing this picture, and if we were to draw lines, you would see that they don't quite touch. Now, having said that, I said a couple millimeters, right? So what happens if the mitral valve is down here? Well, then you might have something called an Ebstein's abnormality. If we have time today, I'll show you what that looks like. And so what am I doing here? Is this a video? There we go. Okay. So again, just another video showing the motion of the valves, the location of the cusp insertion. Look at the moderator band. This is a fetus that's breech spine up. This is another position when the baby is face down and breech that you can see the heart pretty well, at least the 4-chamber heart. Some of the other views may be a little more challenging. And again, we're looking at the squeezing motion and not, the heart is not rocking, it is squeezing. As far as size goes, the cardiothoracic circumference ratio should be less than 0.5. If you get that little tickle in your head when you look at a 4-chamber heart and say something about the size doesn't look right, do a cardiac circumference and a thoracic circumference and do a CT ratio. And if it's greater than 0.6, it's definitely abnormal. It should be 0.5 or less at all gestational ages, although I give you some reference values here. But sometimes your eyeball catches the fact that it looks a little big. But if you're not sure, or if you're doing something like a hydrops or heart failure study, it's always a good idea to get a CT ratio. As I mentioned before, the ventricle should be about the same size. The atria should be about the same size. Right heart structures can be slightly larger than left heart structures, especially at term. The left ventricular outflow tract, and I'm going to have later on in this lecture, I'm going to have the how to get it. Okay, first I just want to go over the anatomy. But in this great picture here, the axis of so the 4-chamber heart is a true cross section. The LV long axis is a slightly oblique view. So from the 4-chamber view, just a slight clockwise rotation is going to get you the LVOT. What are we going to look for in the LVOT? Continuity of the aorta and interventricular septum, the motion of the valves, and the aorta should aim towards the fetal right shoulder. So here is a drawing, left atrium into left atrium into left ventricle out the aorta. Continuity of the IVS. This should all be one long line with no breaks. Look at the valvular motion for the mitral valve and the aorta. Those are the key things in this view. And this is beautiful. This is the LVOT, left atrium and the left ventricle, out the aorta. And then we can see a piece of the right ventricle there. So another image, here's the ISUOG drawing. Again, this is just off axis, clockwise off axis from a 4-chamber heart. And here we can see that aorta headed towards the fetal. This is left, this is right. Aorta headed towards the fetal right shoulder. Now, of course, it doesn't take long for that aorta to loop back around, but we're not there at the LVOT. We're aiming towards the right shoulder. And here you can actually see there's an angle that can be measured to look at this interventricular septum and how it comes up to the aorta. And I don't have the data on exactly what that angle is, but it is something that you can do to quantify if you want. But again, we expect to see the left ventricle and the blood going out the aortic valve. And let's see, is there a video? Here's a video showing, again, this continuity of the interventricular septum, the mitral valve motion, the aortic valve motion. The RVOT is a short axis of the right ventricle outflow tract, and that is a plane that is opposite. So again, I'll show you in a little bit, but instead of, now what you're going to do is go back to your 4-chamber heart. You're going to physically move the probe towards the clavicles and give a counterclockwise twist. What are we looking for? The aorta must be in the center of the heart. If I had a heart in my hand and I stabbed a pen through dead center of the heart, that should be the aorta. And I'll show you a picture, not of a pen in a heart, but a similar version that I use. Pulmonary artery, again, it's a right-sided structure, so it should be anterior. The ductus arteriosus should go to the descending aorta, and the right pulmonary artery crosses underneath the aortic arch. The aorta and the pulmonary artery should be about the same size, but if one is going to be a little larger, it's the pulmonary artery and not by much. And the pulmonary artery aims towards the left shoulder. Remember, the outflow tracts have to cross. Aorta to the right shoulder, pulmonary artery to the left. So this is the short axis RVOT, and the center of the heart should always be the aorta, and then the right heart just wraps around that. So right atrium to right ventricle through the pulmonary valve to the main pulmonary artery. And this is not, in this view, it is not left and right pulmonary artery. Don't make that mistake. The right pulmonary artery crosses underneath the aortic arch. The aortic arch is going over this image. It's in a different plane. But the right pulmonary artery is crossing underneath the aortic arch. The ductus arteriosus goes straight back to the descending aorta. So the descending aorta is here. So right atrium, right ventricle, main pulmonary artery, straight back to the ductus arteriosus into the descending aorta. Right pulmonary artery crosses underneath. This is the short axis RVOT. Remember I said the right pulmonary artery crosses underneath the aortic arch, so I drew in an aortic arch to show you sort of in 3D how the right pulmonary artery comes underneath, and the aortic arch, which you cannot see in this picture because it's coming up out of the screen, is right there. I always describe the RVOT as looking like a snail, and in case you're not sure what I'm talking about, here's what I'm talking about. So it looks like the shell of the snail is here, and then it comes around, and then you've got those two feelers or eyes, whatever they are. So I don't have a heart with a pen in it, but I have a bell pepper. And so whenever I describe this to my students, I ask them, first of all, if they've ever heard of a bell pepper, and they say yes. And so I say, okay, you know that stem coming out of the middle? And they say yes. I say, that's the aorta. And so the aorta should always be in the center. And if I cut open the pepper, the aorta would be right here. And then here's the right heart structures wrapping around it. I mentioned the outflow tracts should cross. So in the 4-chamber heart plane, one of the things we can do is watch in real time as the RVOT crosses this way and the LVOT crosses this way. So you'll see it in a moment. Here comes the LVOT right here. And now I angle anterior. Remember, the right ventricular or the pulmonary artery is anterior to the aorta, right? So here's the anterior pulmonary artery. And if I go more posterior, there's the LVOT going this way. So here I took some stills. Here's the pulmonary artery at that angle. Here is the left ventricular outflow tract and the aorta at this angle. They must cross. The aortic arch view is one that can be challenging to obtain if the fetus is laying on its back, because you have to get it at the right angle. When the baby is face down, when the fetus is face down, it's very easy to get this view through the left spine. So through the left spine, you can see the aortic arch. Notice the three cranial vessels, brachiocephalic, left common carotid, left subclavian, and notice how sharp this arch is. So the descending aorta doesn't go anywhere. The descending aorta is in the same place, no matter what vessels you're looking at. But the origin of the vessel is what changes. So in the case of the aortic arch, the aorta originates from the center of the heart. When we look at the ductus arteriosus arch next, it originates from the anterior heart. So it's going to have a different shape. But because the origin of the aortic arch is more posterior compared to the ductus arteriosus, it looks like a candy cane. And that's what we're looking at here. It's a very sharp curve compared to when we look at the ductus arteriosus. So two things: comes out of the center of the heart and has cranial vessels. I'll show you this brief video. There's a YouTube website, I have the link down here, that goes over how to do the views. So one of the things you're going to see is watch her come through the left spine. Okay, so she's changing the angle of the probe to shoot through the left spine, and now she's going to go sagittal, and it comes right in. Beautiful. So move your transducer. Remember, mom's a fishbowl. Use the whole belly. Moves the probe so that you can shoot through the back of the left spine, and you'll get that aortic arch view, and nice. Here's what a candy cane looks like for those of you not familiar with the sweet treat. But notice how sharp that curve is. The ductal arch, by comparison, originates from the anterior heart because it originates off of the main pulmonary artery and then goes straight back. So it has a much flatter curve compared to the aortic arch. Let me just go back one. Let's look again at this curve. This is a very sharp curve. Notice the right pulmonary artery crossing underneath it right here. The ductus arteriosus goes straight back because it's coming out of the anterior heart. Notice there's no cranial vessels, and it goes right into the descending aorta. So here is the video on how to obtain that. Now for this is a true sagittal plane. So if you have a fetus laying on its back, all you need to do is move the probe sagittal, and you'll get the ductus arteriosus in every single time. So it's just go true sagittal on the fetus, and that will come in every time. It's a nice, easy one to get. Look for the cranial vessels. There should not be any. And make sure that it doesn't look like it's coming out of the center of the heart. Here's what a hockey stick looks like. Sometimes the ductus arteriosus is called the hockey stick view because here's the descending aorta, and the ductus is flatter than what we see with the aortic arch. Notice the ductal arch view is true sagittal plane. The three-vessel view is a transverse view of the pulmonary trunk with the left pulmonary artery and the right pulmonary artery. Notice in the RVOT view, we do not see the left pulmonary artery. It is the three-vessel view where you'll see the pulmonary artery, left and right pulmonary artery. So here's what it looks like in the illustration. And it's called the three-vessel view because you're seeing the main pulmonary artery, aorta, and SVC all in a row. This fetus is breached, so this image is opposite. The three-vessel trachea view is a little of a trickier one, but it's a very important view to get. And what you're seeing is the pulmonary artery and ductus arteriosus and the aortic arch. So that aortic arch is much more superior than the RVOT view. And when I say much, I mean millimeters, because we're talking about very small structures. But you have to remember that in the RVOT view, the aortic arch is more superior. So you need to angle your transducer more superior to get this V shape. And here you see the aorta, the pulmonary artery, and the ductus arteriosus. both of these, the aortic arch and the ductus arteriosus, are headed for the descending aorta. Here's the SVC and the trachea, which is why this is called the 3-vessel trachea view. So this plane, this is from that one of the YouTube videos. I love this image because it shows the plane that you're going to be at, cutting right across the aortic arch, the SVC. The trachea is not in this image, but you can see the pulmonary artery, aortic arch, and SVC. That's what it's supposed to look like. In color Doppler, everything should be flowing towards the ductus arteriosus. So one of the things you'd be looking for is flow going in the wrong direction. And also, of course, disproportionate sizes. Here, oh, thought that was a video. This is the ISUOG example. And then here's the video on how to get it. Now, one of the things I'll tell you is from the 4-chamber view, from the RVOT view, you're going to angle more cephalad. So if you notice her probe is not straight up and down, and that's because to obtain this view, you need to put a tilt in it. And I'll show you what I mean when I get to my other images, because you need to angle to get this view. So here's the RVOT. You're going to tilt the probe back to get that 3-vessel trachea view. The pulmonary veins are not a routine part when you're looking at all the heart anatomy, but you should readily be able to see them, but they're more done with a fetal echo. The long axis SVC IVC view, or as I call it, the right atrial inflow. This is the SVC and IVC. This is a true sagittal view. It lies right next to the ductal arch view. Extremely easy to obtain. And so as you're scanning, you just want to be true sag, and they're just right in a line with each other. Again, I mentioned this before, when you do M mode, even if you're just looking for fetal heart motion, you want to document the fetal heart rate, get your Doppler cursor if you can to touch the right atrium and the left ventricle. Just bisect both of them, because again, you want to see the atrial contraction as it compares to the ventricular contraction to look for arrhythmias. You should be able to see arrhythmias with the naked eye, but still, it's nice to have it documented, even if it's just unofficial. So here's my how-to. Again, the 4-chamber heart's going to be a true cross-section. So for that, you're just going to put your, well, this fetus is breech. It's a lot easier to talk about a fetus that's vertex, so I'm going to flip the baby upside down. Now I can show you the 4-chamber heart. So everything I'm showing you relates to a vertex fetus that's spine down. If the baby is breech spine down, everything I'm saying, just do it backwards, do it opposite. So again, with the baby laying on its back, here is your true 4-chamber heart. It's just a true cross section. Nice. To get the LVOT, all you need to do is just do a slight counterclockwise twist of the probe. Don't angle it, tilt it, or move it. Just turn the probe this way. By just a slight clockwise twist of the probe, you now have the LVOT. Come back to your 4-chamber. Your 4-chamber view is your starting point. Very important to go back to the 4-chamber view. Now, for the RVOT, what you need to do is move the probe. Don't angle, don't tilt, don't rotate. Physically move the whole probe towards the fetal clavicles. Okay, it's just a little bit, just a millimeter or two. Then from there, you're going to put a counterclockwise twist. So now you're angling this way. This RVOT view should come right in. Be very careful about how you're moving the probe. As I said, you don't want to twist it or do anything like changing the angle that you're coming in at. Everything's pretty much parallel to the table. From here, so here's the RVOT, we're just going to move the probe a little bit cephalad, and the 3-vessel view will come in. And now here's where you're going to tilt. Here you're going to tilt the probe back, like I showed you before, as if you're aiming towards the head, and the 3-vessel tracheal view will come in. So again, just a little bit of a tilt back so that you're aiming towards the fetal head, and this view should come right in. So I'm not going to have time for the pathology, but let me just show you a couple things first, because we're running out of time. So what if I see an echogenic intracardiac focus? As long as there's no other markers for Down syndrome or anything else, they're nothing. Okay, so they're of no finding. We don't even mention them. What if I see pericardial fluid? If it's less than 2 millimeters, it's totally normal. What if the ventricles are disproportionate? If it's mild and it's right greater than left, it's okay, as long as it's the late 3rd trimester and there's no other congenital heart defects. What if the valves insert right along the same plane? They have a linear insertion. Well, it could be an atrioventricular septal defect. It could be a normal variant. Keep scanning. Or when in doubt, send it out. Heart motion. This is what we talk about when we say we want to see squeezing. Notice the heart muscles squeezing, the ventricles get smaller. Now, first of all, look at this ductus venosus. If you remember my talk from the other day, and I talked about what the ductus venosus should never do, it was touch the baseline or cross it. So we have a reversed A wave in the ductus venosus. You already know this heart's going to be abnormal. Watch the heart motion. What are you seeing? First of all, you see some pericardial fluid. Notice how the heart is rocking back and forth. It's actually banging left, right, left, right. The heart's not squeezing. This is a breech fetus, by the way. This is a fetus with hypoplastic right heart syndrome. Valve motion. Watch the valve motion. Okay, when we look here, we see 2 valves that are flapping away and have pretty symmetrical motion. Watch the, oops, where's my video? Uh-oh, hold on. Let me get out of my laser pointer here so I can play the video. For some reason, it's not playing. Now watch this one. Notice this valve looks good. That's the mitral valve. I'm sorry, this one is vertex. The other one was breech. What happened to the right heart? Well, the valve's not moving, and that's because there's a hypoplastic right heart. So from the Abu Hamad book, it gives a list of structures that if you see it and it's large or small, these are the things you should look for. Nice handy chart to have. And we're going to not have time for cardiac pathology. Yeah, we're not going to have time for cardiac pathology. So I'm going to end there, but I'm happy to answer any questions. Fetal tachycardia causes in the 1st trimester. Tachycardia, I don't have information on. Bradycardia is far more common, and it usually is impending demise. I don't think I've even ever seen tachycardia in the 1st trimester, to be honest. And I've been doing perinatal since the mid-90s. So I wouldn't know what to say in that, but bradycardia certainly is seen, and depending on how low it is, certainly below 80, there's almost no chance of survival in the 1st trimester. But tachycardia, that's a new one.
Doctors, if you have any question, please put it. Otherwise, we need to close the session.
Irregular rate, there's a lot of potential causes. So arrhythmias can be idiopathic. Fetus just has one. But if there is, depending on the type of, whether it's a complete heart block or 2nd degree, there's all different kinds of arrhythmias. If it's an intermittent PAC, nobody cares. There's of no consequence. It's never going to cause any kind of heart failure. But if you suspect if it's a regular arrhythmia or something like a heart block, you want to do testing for antiphospholipid antibody syndrome and lupus. Check the SSA, SSB titers, things like that. So it just depends. It could also be a conduction issue with the fetus. I mean, there's a couple things that it could be. So you want to do a fetal echo and get some blood work done.
I think that's the end. There's no more questions.
Thank you all for your great questions
Thank
and for your attention today.
Yeah. Thank you, Dr. Tracy.
Thank
Dr.
you,
Tracy, that was a lovely talk.
Thank you.
That's Mala Sibyl, yes, a lovely talk.
Thank you so much.
We will conclude the session here. Tomorrow is the last day. You all requested to be on time. And there is an exam as well tomorrow. There is a multiple choice question from all speakers. I put one as exam. So you need to be pass the exam to get the certification. But it's not very hard. It's mostly from the lectures that we delivered from last 4 or 5 days. Okay, we will conclude the session here.
Thank you.
very
Goodbye,
much,
everybody.
Dr. Tracy. Thank you, Dr. Mala. You can also join Dr. Tracy tomorrow if you have a time. Oh, she left it.